I'm Myron Posniak from the University of Wisconsin. We're going to discuss CT evaluation of trauma in the emergency department. Trauma is a big factor in the work that I do as an abdominal imager. I'm at a level 1 trauma center, and we see a fair amount of it. It's the leading cause of death in the first 4 decades of life. Approximately 150,000 deaths per year in this country from trauma, and about 2 million non-fatal injuries. I looked at the National Trauma Data Bank, which is compiled by the surgeons, and there's some interesting statistics. So first of all, this is patients by age, and then you can see there are peaks in traumatic injuries as we go through time. The first peak in the youthful age is from firearms. In this country, that's probably a very controversial issue these days, but it is what it is. In the mid-age range, it gets to be the MVAs. There's a peak from those. And then in the senior years, the traumatic deaths come mostly from falls. And when we split this out into male and female, it's the young guys who end up shooting themselves and driving their cars erratically. And then in the older years, there are fewer men around, and so it's the women who dominate with the fall statistics. There's one other curiosity that I found when looking at the data, and that's the mortality, the fatality rates by mechanism, and firearms have just a much, much higher fatality rate. Again, another aspect of society that we live in. Alcohol has a significant role in this. About 10% of accidents of MBAs involve the use of alcohol, and drug use as well. So trauma management has evolved. Years ago, people used to die in the street, but now we scrape them up, throw them on a helicopter, and they're in the emergency department, and it's up to us to try and help them. So what we need to do is obtain as much information as we can, as quickly as we can, so we can treat these patients accordingly. Now, I will say one thing. The critically unstable patient does not belong on the CT scanner. They belong in the operating room. Why do we do CT? Well, we have an unexplained drop in hematocrit. We may have a confusing physical exam, but we want people who are hemodynamically stable. By that we mean that the fluids that are being put into the circulatory system at least equal the fluids that are coming out, so this patient is not going to crash on you on that CT scanner. You shouldn't be running codes there. That patient belongs in the OR. Their chance for survival is greatest with a diagnostic surgical procedure. Now, let's say the patient is stable. What are we going to do? Well, there are 2 options. There's ultrasound and there's CT. So ultrasound is really performed by the ED docs. Sometimes they know what they're doing. Other times we worry about them. But they're looking for one thing. They're looking for intraperitoneal blood. They may look for organ laceration, and some people suggested even using contrast for that. But personally, I think it takes too long, and it does not give you the big picture. Finding fluid in the cul-de-sac, fluid in the pleural space or around the liver, they're good at that. They can find, and if you see large volumes of fluid, they may just say, no, we got to go to the OR, this person's on the edge. Finding lacerations of the organs, you can do that if they're big. The subtle ones are tricky. A little hematoma, a little clot sets up, and the echogenicity can mimic that of adjacent tissue. And besides, if you have an injury like this in the liver, what's not to say that you don't have an injury in the kidneys and elsewhere? Really, the CT gives the big picture. The advantage of ultrasound is it's quick, it can be done at bedside, and it identifies the patient that needs to go to the OR emergently. The disadvantages, well, obviously operator dependence is a big one, but if you have only a retroperitoneal injury, or if injuries are not capsule disrupting, they will be missed because you are not going to see a large volume of free intraperitoneal fluid. CT, it's non-invasive, it's pinpoint, where it's very, very accurate. And the good thing with CT, you can, nowadays non-operative treatment is very popular. We just watch. And if crit drops again, well, you can repeat a CT scan. So it does allow non-operative management. You can compare, are there changes? Disadvantages are radiation, cost, IV risk. We're also bowel, pancreas, and diaphragm immediately. Some of these injuries take time to evolve, and it is a relatively time-consuming study. Now, the scan itself takes, 20 seconds, maybe 30, but it's getting the patient set up in the scanner, getting the tubes and lines anchored, making sure that the patient can move through the scanner without anything falling out or getting pulled. That's what takes time. So what's used, CT versus ultrasound? Well, it's the trauma manager's preference. They really need to make a decision. Do we rush to the OR? Let's take a quick peek with ultrasound. If the patient is stable, then they will choose to go for a CT scan. So on our side, if we're going to be providing that service, we need a scanner close to the ED. We've got a scanner right across from the trauma bays in the emergency department. It's a sub-second rotation, multi-detector system, big tube, power injector, and it's got all the remote patient monitoring equipment that we need. We do not hesitate to sedate patients if they are combative. And now with alcohol, drugs on board, they can very easily be combative. Or if they've got a head injury and they're confused, they have reversible agents. We will sedate. We want, if you take a picture of somebody and they're moving, it's useless. So we want the patient to be still for that scan, and then the agent can be reversed quickly. We don't bother with oral contrast. It takes too long. It increases the risk of aspiration. We don't bother with it. We clamp the Foley catheter. I want to stress the urinary system. If there is a bladder or a urinary tract injury, we want positive pressure to develop, so it pushes the urine out and makes it easier for us to identify. And we minimize artifacts, like getting tubes and lines out of the way, getting the EKG leads off the patient. I don't want this adding confusion to the interpretation. We get the arms up, if possible, because we want to avoid this kind of artifact. Now, you can't always do that. If there's a big fracture, clavicle, whatever, the patient may not be able to do that, but you can see how much harder it is to interpret when you have that kind of artifact. Work with your EMS services. Get the metal out of the boards. You don't want to add that artifact, but not all metal is necessarily artifact. The carpenters these days, they've got those fancy nail guns, and they can do pretty impressive things with them. That one, not so bad. It's in the liver. This guy was looking into the gun just to figure out what was wrong with it at the time. That he missed his eyeball. But how about this one? Take a look at that again. Ouch, that is not one I want to pull out. I think that went to the OR. Technique. First of all, we use contrast, IV contrast. We give a liberal amount of it. We follow it with a saline chaser. We're usually injecting at a brisk rate, 4 or 5 cc's a second. If the patient has a big traumatic chest injury, we will use bolus tracking, because if the patient has a significant cardiac contusion and their cardiac output is decreased, the perfusion time may be slowed, and you don't want to have the injection go in and not have the contrast circulate appropriately. Of course, you can get a delayed scan, but that's extra radiation. There is no role for non-contrast CT in the evaluation of the trauma patient. It adds nothing. What you're looking for is vascular disruption. You're looking for that big leak of contrast, like you're looking for the organ parenchymal disruption, and you're not going to see that without IV contrast. So how do we perform our studies? With the patients on the table, and we start at the diaphragm and we scan up using CT angiographic technique. Then we go back to the diaphragm, we scan down through the abdomen and pelvis during the parenchymal phase of injection. The arterial phase here, because we're looking for disruption of the aorta. We want to make sure we don't miss a traumatic aortic laceration. And then in the abdomen, it's mostly looking for parenchymal injury, and we give enough time, if there is a vascular disruption, for acute extravasation to occur of contrast, and then for us to be able to pick that up. If there is any fluid around kidney or bladder, we will do a delayed sequence at 7 minutes. So the first scan is popped up quickly. The tech transmits it to the reading room and asks the radiologist or the resident on call, give it a quick check. Do I need to do a delayed? If there's no fluid in the peritoneal cavity, if there's nothing around the kidney, if the bladder looks good, no, we're done. But if there is some fluid around there, we'll get a delayed sequence at 7 minutes. That's usually enough time for the bladder to fill with contrast. If you noticed, our technique was fairly narrow collimation here in the chest, because we want to reconstruct the aorta with great detail, looking for intimal tears. In the abdomen, great detail as well, but that's primarily because we're doing targeted bony anatomy reconstruction. T&L spines get reconstructed on just about everybody these days, and you need those thin slices for those recons. Now, some critical observations. Always look at the scout. That is going to be your quickest and easiest way to pick up a tension pneumothorax, all right? And this one, it's pretty obvious. There it is. You know, on the CT, you might go past it. Sure, you can see the pneumothorax, but is that shift of the mediastinum, I'm telling you, I think it's much more conspicuous on the scout view. There's one on the right, here's one on the left. You can see how it's pushing things over. You can also pick up on an ileus or a possible bowel obstruction really quick. And in this case, you know, if there's a resident involved right in the scan, they may say, "Hold, stop, don't inject yet, let me go put a tube in and get this tension taken care of." I like to tell the residents, look at the box. So you get something from UPS, there's a big gash in the box. Obviously, what's inside isn't going to be in good shape. So if you see large body wall hematomas or even small ones like this, there's an indicator, and likely, you know, look right under that because you may find the laceration. That area where the hematoma happened is where the impact hit, and the underlying organ is more likely to get injured. Look for free fluid. It's really important in the belly because it could be any of these fluid products. And then look at the attenuation of the fluid. If you see it increasing as you go more dependent, this is likely blood within the peritoneal cavity. This is basically a hematocrit level that is developing slowly over time. A little rib fracture over here, right? So it doesn't look significantly displaced. Don't be fooled by that. Remember, during a traumatic impact, you have coup and counter coup. Those crash test dummies, they're going over the over the steering wheel, and then they're going way back over the back of the seat. With those forces, there's energy that's being built up, suddenly a rib will snap, and as it does so, there's a lot of release of energy. This thing moves in all over the place. It can hit the lung, it can hit the liver, but then with counter coup and the elastic properties of the tissues that are holding the fragments together, it tends to bring them very close back to where they were. And so what looks like a non-displaced rib fracture was probably significantly displaced at the point of impact. In this case, lacerating the liver. So just have a low threshold, low suspicion for calling organ injury related to rib fractures. The non-displaced, that's kind of a misnomer. All right, and let's see, here, you look at this scan, you've got some high attenuation material here. Well, are these fragments of bone here? Was this a fracture, or is this active extravasation? If in doubt, get a delayed scan. The delayed scan is your friend, all right? Things with hemorrhage are happening quickly, fluids accumulating, you're gonna have an easier job of diagnosing the hematoma. All right, now, very important point. We talked about this yesterday with aortic injury. The same thing here. Very important statement. The size of the potential space is the key determinant of survival. What you are bleeding into will determine whether or not you need surgery or whether or not you're even going to survive. So this bleed into the soft tissues of the body wall is going to basically, the pressures in the artery are going to equilibrate with the buildup of pressures in those soft tissues. That's why contused soft tissues end up feeling woody, very rigid, because pressure builds up in compartments. Well, but actually that's working to the advantage of the traumatized patient, because as that pressure builds, it's now counteracting the pressure in the vessel, and less blood is escaping. Eventually it'll equilibrate and the bleeding will stop. However, this patient who has a major liver laceration is bleeding into their peritoneal cavity. This bleeding will maybe result in millimeters of volume loss. This will result in liters. This patient's going to need intervention, okay? Here's a renal laceration, all right? Do we operate on this one? We can observe this one. This is a relatively small space. Gerotus fascia, contents within it will pressurize, the bleeding will stop. You can just watch this one versus bleeds into the peritoneal cavity. Those need to go into the OR. All right, let's look at some specific organs. The aorta, 63% of MVA deaths are attributable to aortic rupture. Most of them die on the street. They're dead. 94% of them are dead within an hour. They don't even make it to the ambulance or the helicopter. You're not going to see them. But the ones that do make it to the hospital, a high percentage of those will die within 24 hours if not properly intervened upon. So aortic injury, what are we going to look for? Well, the mediastinal blood collection is always something that worries people, and I'm going to tell you, you need to back away from that. So if you look at this CT scan, you're going to say, wow, there's some blood along the aorta. So how many of you are going to read that as can't rule out aortic injury? All right, just be careful. Most of these bleeds are venous. Most of these bleeds are from just a little tugging and that causes a small venous tear, and that blood accumulates and gives you the concern that this aorta is not intact. Well, we had a series of about 20 of these early on as we were interpreting these cases, and all of them, we ended up calling the angiographer. It was the middle of the night. Those guys hated us, and I'll tell you that all of them were negative, no aortic injuries. So realistically, use CT angiographic technique. You're not going to miss aortic injuries. You're not going to miss those little intimal tears. You don't want to yell wolf and have people do procedures that are unnecessary. That small mediastinal collection of blood, more often than not, is nothing. So here's a case, maybe there's a little mediastinal widening, right? And then clearly here's an aortic transection. Here it's seen on the reconstructed view, and these patients end up with stents these days. This is the way to treat them, but also your job is to identify aberrant vessels, because treating with stents, you want to make sure that you're not dealing with an aberrant left subclavian. This one will cause problems for the individual trying to put in one of these stents. Endovascular repair of aortic injury is now increasing rapidly. Why? Because emergent aortic surgery had a very high mortality rate. Again, this was a space that contained the bleeding, but as soon as a surgeon cracks the chest and opens it up, the bleeding reestablishes, and that's the aorta. It's vigorous. So the ability to get in there and cross-clamp the ascending aorta, no matter whose hands it in, it's hard to do. And so a high percentage of these patients used to die. With endostenting, the success rate is much, much better. Now, there are some adverse effects, paraplegia and stroke, but it's a hell of a lot better than mortality. Okay, now, what do you think of this aorta? Or that one? Okay, these are little raised intimal flaps. So this is a patient who had a rapid deceleration injury, but it was not so rapid that it transected the aorta completely, just little intimal tears. So remember, you have in the blood vessels, any artery, you have an intima, a media, and the adventitia. The media is that thick muscular wall that holds in all that pressure. The intima is a relatively thin layer. It's like Teflon. It keeps blood cells from sticking on it. The media is more elastic. It can stretch. The intima, not so much. It's more brittle. And so if a patient has just the right decelerating forces, they can tear the intima, but the vessel itself still has integrity. And so you end up with these little intimal flaps that stick into the lumen of contrast. We can pick these up. So are we going to treat these? How about this one? This one's actually got a little bit of ulceration developing in it already. Contrast is oozing under that flap. We don't know the natural history of these, how these are going to evolve. The policy is that we need close follow-up on these patients if they're going to be doing non-operative management. So once the intima tears, it creates a pathway for the pressure within the aortic lumen to pump into that aortic wall, and eventually what's going to happen is you end up with little pseudoaneurysms, and then these can grow. This was a post-traumatic intimal tear that had a 6-month follow-up, and look at this massive pseudoaneurysm that developed. So just be aware, small intimal tears, you should include in your report the suggestion for follow-up scanning, because the risk of pseudoaneurysms is 5%, and these can rupture. With intimal tears, also dissections can develop, and you hopefully know about these already. All right, splenic injuries, about 9%. It's the most commonly injured organ. We look for organ disruptions such as this. The trauma surgeons have grading scales. I don't like to use them. Personally, I think they're out of touch with today's imaging techniques. They're really for research purposes. I tell my residents, if you're busy on call, don't bother. If you look at this, really, who cares about these kind of gradations? What's most important is there active extravasation or not? Is the organ intact or is it fragmented? Those are important criteria. Here's a patient who had a little splenic laceration. All right, 4 days later was rescanned because there was a drop in hematocrit. In this patient, observation failed, rebled, went to the OR, had a splenectomy. I'll tell you that the vast majority of patients who we scan for a drop in hematocrit post-trauma, we find nothing. It's hemodilution. Some nurse had the IV running vigorously, they drew bloods, the crit dropped, they got worried, they got a scan, we find nothing. This is an oddity. Maybe 1 or 2 a year do we find that have delayed bleeds. But here's an interesting one. This patient obviously had a splenic injury, follow-up 8 days later, and now there's an unusual accumulation of contrast here. What do you think we're looking at there? Pseudoaneurysms. Any vessel with the right amount of deceleration and intimal degradation can develop pseudoaneurysms over time. Liver, second most common injured organ. Penetrating injuries, not so much, but this is an important concept. Shear injuries along stress risers. A stress riser is a weak point in the system. If an architect is building in an earthquake zone, they make sure the building has uniform structural integrity throughout. You don't want to have a floor that's particularly more rigid than another, because that then becomes the focal point at which energies start to focus and the building can collapse. And the same thing in the liver. There are structures, anatomic structures, that focus shearing energies, forces, and you get these kinds of shear injuries. Note this one, from the cava along the hepatic veins right out to the edge of the liver. There's a hepatic vein right there. So stress risers are very significant. Here's one, the shearing injury is right across the falciform ligament. It just extended on upward. Just keep that in the back of your mind as you're looking at trauma cases. And now, in this era, interventional embolization is getting more and more popular. So really only 4 out of 5 patients who we see acute bleed end up getting intervened upon, and a lot of them now, instead of going to surgery, will get interventional embolization. So what are we going to do with this case? There's a big injury in the posterior right lobe of the liver. Do we intervene? Do we follow it? You know what? I don't see any active extravasation of blood, even though that's a big injury. These just get followed. Renal trauma, direct blow, maybe laceration by a liver, but stress riser, again important. Hydronephrosis, fetal lobulation, underlying cysts, those are points at which stress is imparted and injuries happen. Gradation, and the vast majority of these are managed non-operatively. Again, they are within gyrotous fascia, leave it alone, let it heal. Grade 1 is about 80% of injuries. These are contusions, little focal areas of decreased perfusion, maybe a little subcapsular hematoma. Note, it spares the hilum. Grade 2, non-expanding hemorrhage. You can see a subcapsular, a little perinephric hematoma, maybe a little laceration. This is a grade 3 injury, but they don't involve the collecting system. There's another one. Grade 4 injuries extend into the collecting system. That's why you need those delayed scans to see the extravasation of contrast. One other important point. With patients like this, the creatinine level is going to go up because that urine is rich in creatinine. It just spilled into the soft tissues. It's becoming reabsorbed. Creatinine is recycling in the body, therefore creatinine levels are going up. Guess what? Don't bother getting creatinine levels in the emergency department because this is the kind of patient who really needs the contrast to identify the injury, and you're going to miss it. Vascular injuries can be completely, vessels can get intimal tears, can get transected, and you end up with non-perfusion of a kidney, decreased perfusion, or in this case, non-perfusion to a segmental area. This is a polar artery injury. 10% of patients have these little arteries going directly through the capsule into the kidney. Segment 5, grade 5 injuries are shattered, devascularized kidneys. Guess what? In this age, we leave them alone. If you go in there surgically, these are going to end up being nephrectomies. You can't put this back together again. Devascularization. All right. Bottom line, 85% of kidneys, 90% of kidneys are salvaged without surgical intervention. All right, let's move on. We're running out of time. Bladder trauma. 10% of all GU injury involves the bladder, and there's two main types we have to consider. Intraperitoneal, these are usually related to seatbelt injury. Pressure comes in from the outside, and the path of least resistance for the urine in the bladder is to pop up through the dome of the bladder into the peritoneal cavity. Extraperitoneal injuries are usually related to pelvic fractures that come and lacerate the base of the bladder. So on cystogram, contrast will spill into the peritoneal cavity with intraperitoneal injuries and then into the soft tissues of the pelvis with extraperitoneal. So this curious collection of contrast is extraperitoneal. It's coming up along the psoas. That's an extraperitoneal pathway of spread. On CT, the intraperitoneal extravasation is between bowel loops and extraperitoneal within the musculature of the pelvis. We don't do X-ray cystography anymore. We do cystograms on the table in CT if we need to. We use some dilute contrast, put it in, and we get a scan like this. It makes it just a slam dunk. You know immediately if there's an injury. Urethral injuries are typically at the urogenital diaphragm, and it will elevate the base of the bladder. With those kinds of injuries, placement of Foley catheters is usually a misadventure. As you can see, contrast down here from a retrograde urethrogram ends up going down the into the soft tissues of the pelvis. Urethral injuries usually result in elevation of the bladder, and that is due to the fact that the hematoma accumulates under the bladder, pushing it up. We're not good at intestinal injuries, okay? We don't use oral contrast. It takes too long. There's an aspiration risk, and the patient is likely, this contrast isn't going to go anywhere anyway. If there's significant injury, there's going to be an ileus. Sure, if you gave it in an extravasates, it's easy to find, but most of the time, you're not going to, it's not going to go anywhere. What we look for is collections of blood in proximity to the duodenum, thickening of the duodenal wall, maybe an intramural hematoma, or air and blood extravasating out. Duodenum is a commonly injured organ. It's right in the path of the airbag, and it gets pressed against the spine, and it's also fixed. It's not freely mobile. It doesn't have a mesentery. We're not good at looking for contusions or mesenteric hemorrhages unless the patient is obese. Body habitus makes a big difference. So here you can see a mesenteric hematoma or an active extravasation of blood or intramural bowel hematoma. These can actually lead to bowel obstruction. And don't forget to check for free air. Use your window width and level settings. Make sure you identify free air because that is really good for identifying any kind of perforated bowel. Okay, what do you think about this bowel? Emblazon this in your memory. This is shock bowel. This is an injury of hypoperfusion. This patient was profoundly hypotensive for a prolonged period of time. This is not from a direct blow to the gut. Remember, the gut is very highly metabolic. And so with ischemia, it's very susceptible to injury. There's a breakdown in the basement membranes. When you inject contrast, there is leaking of contrast through the basement membrane into the tissues, and so the bowel folds, the walls become hyper-enhanced, and the bowel is just typically sitting this. What does this mean? Well, this means that this person is toast, because if the bowel is looking this bad, the brain isn't any better. All right, so this is a bad finding. We're not good at pancreas injuries because most of them take time to evolve. Yes, if there's an acute fracture or an acute blood collection, that's one thing. But most of the times, pancreatic injuries take a week to manifest as pancreatitis, and then maybe 2 weeks to develop a pseudocyst. We're also not good at traumatic injuries of the diaphragm. Mortality rate's pretty high, but that's usually because it's, if you rupture the diaphragm, you're likely to do a lot of damage to yourself. Incidence about 4 to 6% of MVA cases. Why we don't do well is because these people are typically in the ED on positive pressure ventilation, and that's pushing everything down. Really, for us to make the call, we need to see the herniation. So we miss about 70% of them. Here, the liver is herniating. Here, omentum is herniating. Stomach can herniate through there. If you're doing the CT scan and you find this, speak up, all right? That's a flat cava. The flat cava indicates that this person is likely underhydrated. They need to get their fluids up. These people can crash fairly quickly. All right, one more curiosity. This person was writing something as they were in the passenger seat, and they couldn't find the pencil after the trauma. We found it for them. All right, conclusion. A, hemodynamically stable patient. You don't want to run a code in the CT scanner. Use angiographic technique for aorta. Parenchymal enhancement is critical. Delayed scans for urinary injury. Don't bother with creatinine levels. Don't bother with oral contrast. All right, thank you.